anyone has any, if anyone wants to watch it again or send it to a fellow soccer parent, feel free to share it. Yes, so thank you for joining our webinar on overuse injuries in young soccer players. Just a bit of housekeeping, if you can please put any questions you have in the chat, and Dr. Boyd will answer them after her presentation. Now I'd like to introduce Dr. Christine Boyd. She is a pediatric sports medicine specialist with more than 20 years of experience. Dr. Boyd is the medical director of Stanford Children's Sports Medicine Program, and she sees patients in our Pleasanton clinic. And she's also an athlete herself. She ran track at Stanford. We were just reminiscing about her track experience and watching the Olympics now. And she's also the mom of 2 club soccer players. Her daughter played for Pleasanton Rage and now plays soccer in college, and her son currently plays for Ballistic United. So she has that real understanding of the challenges of staying healthy while playing competitive sports from multiple angles. Without further ado, here's Dr. Boyd.
Awesome, thank you, Amy. So welcome here on Friday afternoon. I am going to roll right into my slides here. I'm going to share my screen and get going. Give me 1 second. Amy, if you give me a thumbs up when the screen sharing works. I know there's a delay.
It's working, thank you.
Awesome, okay, great. All right, so for the next probably 30 minutes, I'm going to just go through some background about overuse injuries, specific to young soccer players. We do see a lot of overuse injuries in our clinic, but I'm going to stick to things very specific to youth soccer players. And then afterwards, we're going to have time for lots of questions. And so I can't cover everything in my 25-30 minutes of chatting. But I'm happy to answer questions afterwards, hopefully somewhat related to the topic we're talking about. So as Amy mentioned, I do come at this from kind of a varied background. I was an athlete. I don't really call myself much of an athlete anymore. I'm more of a chauffeur. But as an athlete, I did run at Stanford. As a parent, I do have 2 kids who still play. And then obviously I take care of a lot of injured soccer players in the office and on the sidelines. I've gotten, I do coverage on the sidelines as well. So I see it all. I definitely understand the intensity of these kids and their commitment and wanting to stay on the field. And so I really try to appreciate that when I'm managing their injuries. So overuse injuries. We're going to talk about definition, some risk factors, some of the most common ones. And again, I'm going to stick with soccer specific and young athlete specific because I can't cover them all in 30 minutes. And everything I'm going to talk about today, I've seen at least 1, if not 10, of these diagnoses, these situations in the last 2 or 3 months in clinic. So this is stuff we see a lot of. And so it's pretty easy for me to chat for hours about it. We're going to talk about diagnosis and treatment strategies, and then more importantly, how to prevent them. They are going to happen, but how do we prevent them from happening so that these kids don't lose time on the field? So again, overuse injuries account for more than half of sports injuries in the middle school and high school athletes. They do have long-term consequences, so we do need to be mindful of them, and they are preventable. We joke in our office that the 4-letter word that nobody wants to hear is rest, because it is quite traumatic to tell somebody that they have to limit or stop their training or competing. So again, we use that word very carefully. So the definition of an overuse injury is an injury caused by repetitive physical stress without adequate recovery. Hold on 1 sec. I don't know, Amy, I've got this thing. There we go. Never mind. All right, so they develop over time. Hold on, now my screen's not working. Okay, when the training load exceeds recovery. So when we talk about training load, we're talking about the volume of working out that somebody is doing, whether it's playing soccer, training, running, lifting, doing agility, doing technical work. That's all part of the training load. When the amount of load exceeds the body's ability to recover, that's when overuse injuries start to occur. Also occurs when there's a large volumes of the same movement. Even if there's not a ton of overall volume, but you're doing the same thing over and over and over, that body part might start to break down. So when you have an overuse injury of a bone, you typically would develop a stress fracture. When you have an overuse injury of a tendon, you're going to get tendonitis. When you have an overuse of joints, inflammation. Specifically, when you have a growth plate that is overused, you will develop a certain type of fracture called a Salter-Harris fracture. That's just a term we use to describe how a growth plate is affected. If you have an overuse injury to a growth center, we call that an apophysitis or an avulsion fracture. Now, I'm going to talk a lot about that in a few slides. And in fact, the majority of what I'm going to focus on probably are the stress fractures and the apophysitis. So 1 in 5 on this front. So the progression, the typical progression of an overuse injury is, you might be a little bit sore after practice, you might be a little sore after a game, but you're still able to do anything. And then maybe you're a little sore at practice, but you're able to train still, you're able to play, it doesn't really affect you, but you notice it. But then if that keeps going and you ignore it and you keep pushing through, you might develop increasing pain that limits your ability to train and play. You're having to modify, can't do the fitness, have to limit your minutes in a game. And then finally is pain with rest, pain whenever you try to do anything. And that's really when we have to intervene. Obviously, we'd like to try to catch it in phase 1 or 2 and turn things around and head the other direction, but it's not always possible. So risk factors for overuse injuries, we use the phrase too much, too fast, too soon all the time. And I think it encompasses most of what causes overuse injuries. So too much is multiple teams, multiple sports, week-long camps where you have 2-a-days, not sleeping a whole lot, playing 2 different sports, 2 practices a day, things like that. That would be considered the too much. Too fast is if you went from doing nothing over summer and then started back in the fall season, and day 1 you were doing a significant amount of fitness activity, or you moved from a recreational level to a competitive level, or you can move from one club to another club that has a different focus on different skill set, and it's a sudden change to your body. That's a good time to get an overuse injury. And lastly is too soon. So if you return too soon after an injury, or even an illness, sometimes I'll have kids who are out for 2 weeks for some either illness or medical reason, and then right when they jump back in, they try to jump back in at the exact same place they were before, and that also can trigger an overuse type injury. Another risk factor is sports specialization, which I will talk about at the very end. Sleep is a big one. Not going to talk about it much in this slide, but I have to mention it at least twice because it's important. There are studies that show insufficient sleep does increase your risk of injury. The goal for kids is anywhere from 8 to 10, sometimes even 11 hours. When the sleep goes less than 8, the rate of injury does go up, especially in adolescent athletes. Nutrition is a big one as well. We had another webinar previously by one of my partners, Dr. Balaji, which is available. Amy can help us with that. That is available as a link that you guys can watch that, where he talks a lot about proper nutrition. And then the last thing, risk factor for an overuse injury, and again, it's last and it's highlighted because it's a big one, and that's the developing skeleton. So the body, when it is growing, has a decreased ability to tolerate mechanical stress, which causes the early breakdown. And also during growth, the athlete develops strength and flexibility imbalances, which also creates a high-risk situation. All right, so here's some anatomy. Developing skeleton. Young athletes, they have the similar injury pattern, 50% overused, 50% acute, but different structures are involved. So if you look at these 2 pictures over here, these 2 right here, you can see there's difference. This one has a line coming through here, and this one does not. This is the knee of a 10-year-old. This is the knee of a 20-year-old. So those lines right there are where your growth plates are, and they're open here, and then they fuse there. So when they're open like this, they're a little bit fragile. They're a little bit gentle. This is where a lot of your knee, where a lot of your height comes from. These are the weak link in the knee, and then in other joints of the body. Bones typically break before ligaments tear. Not always, though. It doesn't mean you can't have a tear in a ligament in a 12-year-old, but typically bones would break first. The highest risk is during the active growth spurt. During that time, again, there's some strength imbalances. There's a change in your center of gravity, and also flexibility decreases during growth. So we treat athletes in the developing skeleton differently sometimes than the adult. So there are some fractures that in kids or even adolescents, we will treat with casting and conservative care because the developing skeleton can heal them, versus in an older athlete or a college athlete, they would clearly need surgery. Sometimes with young athletes with certain injuries like a patellar dislocation, we might be more aggressive at short-term immobilization than an adult who we're going to send back earlier. So sometimes we will tend to immobilize a little bit more in the younger athletes than we do use physical therapy in the older ones. And monitoring growth in young athletes can help identify periods of increased risk. And it doesn't necessarily mean you have to be out there measuring the kids every day. But if they're outgrowing their shoes or outgrowing their clothes, they suddenly wake up and they look a foot taller. That should ring a bell that, hey, maybe there's I got to be mindful if there's aches and pains, that we've got to take these a little bit more seriously. Speaking of growth spurts, we call it the peak height velocity. That's the medical term for the big growth spurt that we see. And again, in girls, it happens before boys. There is a wide range of when it happens in kids, both boys and girls. Girls can start as early as 10. They're usually done by 13 or 14. Boys usually start more like 13 and end more like 16. And again, this is the rapid growth, not all growth. So your muscles and tendons, so your bones grow first. When you're growing and you're getting taller, the first thing that happens is the bones get longer. Once the bones get longer, the tendons and muscles immediately just get stretched tight. And then they have to relax and become more flexible to deal with the new length. That is what causes a lot of the decreased flexibility in the developing skeleton. There's decreased coordination. Again, longer limbs, bigger feet. Their core gets not as strong. Center of gravity changes. I could not help do a talk without some Taylor Swift reference. So those of you who know what this is will appreciate it. But there's a lot going on during the peak growth spurt. Injury risk is not related to overall height. So you'll see in this picture to the right, these might all be 12-year-old boys of varying heights. It's related to the rate of change. So you might have the tall guy who's not going through active growth, who's just doing, slow plodding along growth, but the short guy who's doing a lot of fast growth, that's the one who actually is going to have more issues than the tall one who's in more of a quiescent state of development. A couple more anatomy slides and then we'll jump into some conditions. So this is an important thing also. I think I discussed the structure of the apophysis probably at least 5 times a day at the office. It's something that is important to understand. And so what an apophysis is a growth center. So this part here, that's your growth plate. That gets you taller, gets you bigger, gets you longer. There's this other part called the apophysis. That's this guy over here. And we're going to see lots of x-rays of it in just a second. It's responsible for the shape of the bone, but more importantly, it is where muscles attach. And obviously in athletes, muscle attachments are very, very important. It also is a weak area. So it is the weakest link during your growing times, is this growth center. And the good news is when you have injuries to this area, they typically heal really well. The bad news is they can take longer than just a simple muscle injury. And if you're not careful, they can lead to permanent damage. So that's why we're a little bit, cautious, and we want to make sure we get the diagnosis correct. This is a really busy slide, and if you ever want to go back and pause this and look at it, it's a pretty cool slide. I couldn't help but not put it in here. This basically goes over all of the areas where there are apophysis, so those growth centers I was referring to. So for example, in the foot, there's one on the heel, there's one on the outside of your foot, there's one on the front of the knee, there's one on the bottom of the kneecap, there's a whole bunch of them on your pelvis. And these are all where the important muscles attach. So this is where your hamstring attaches. This is where your hip flexors attach. This is where your oblique muscles attach. Your patellar tendon, your Achilles tendon. And so as we go through these, you'll realize that these are the places that a lot of growing athletes will complain of discomfort and pain. And that's because they're soft areas with big muscle groups attached that are getting overworked. It's repetitive traction that causes the injury. So it's not just, not just one time running is going to, damage your skeleton. It's usually multiple times over and over, which cause inflammation. And then as there's inflammation there, it gets weak and then it can cause a fracture. So this is usually the cascade of the pattern we see. They appear and they fuse in a pretty predictable manner. So I can usually tell if a kid comes in based on their age, what growth centers are going to be open or fused and kind of determine injury patterns. Like for example, well, I'll go over in a second, but the knee, the ascending Larsing, the top one up here is a lot earlier than the one down here. And same thing on the hip and pelvis. If I have a 13-year-old soccer player come in, they probably injured this purple one down here. If I have a 16-year-old come in, they probably injured more of the green one up here. So It's actually surprisingly predictable. All right, so these are the ones we're going to target in the next few minutes. We're going to talk a little bit about the hip injuries and avulsion fractures of the hip. You'll hear a lot of people talk about I broke my hip or I fractured the growth plate in my hip. That's what this is. We're going to talk a little bit about the Osgood-Schlatter knee pain, and then some stress fractures in the lower leg, feet, and then I wanted to add in the stress fracture of the back because it is something we're seeing more of, and it's important just to be mindful of it. All right, so just because my kids ask me this all the time, and they get them backwards. On the front of your legs are your hip flexors and your quads, and on the back of your legs, your hamstrings. I know most people know that, but in case you get them backwards, the ones in the front are responsible for kicking and sprinting because you bring your knee up. The ones in the back are more responsible for sprinting, not as much the kicking, unless you're sliding in for a tackle or something and overextending. So the typical injury is this, when you're either kicking or sprinting and you feel groin pain and or a pop, the typical story. Muscle injuries like this one, so pulling a muscle, tearing a muscle, straining a muscle, that's all the same thing. And it all means micro tearing of the muscle fibers. And yeah, there are different degrees of injury, but it all is the same concept that the muscle is overstretched and has tearing in it. We're going to see muscle strains more in the older teenagers. They're not as common. They're possible, but not as common in our youngers. The risk factors for having this type of injury to a muscle is a tight muscle, a weak muscle, or a tired muscle. And that's where the overuse piece comes in on this. It's muscles that are tired and are extra sore after practice for a week or two are much more likely to develop this injury than a muscle that's happy and rested and feels that's not previously sore. Muscle injuries in young athletes, though, are often related to the growth center on the pelvis we're going to talk about in a second. So at this age, when they're looking gangly and teenagery or preteen, the tweens, those are the ones that I am on high alert for bony involvement. Again, so these are some pictures just to show you some examples. This one up in here, this is a pelvis. This is called the ischium. This is where the hamstring attaches. And on this particular athlete, it should look like this. But instead, it's got this big area of thickening right in here. That is inflammation of the growth center, or we call this apophysitis. So a kid like that's going to have a lot of tenderness over the bone, maybe down into the muscle, pain when they try to stretch. The other thing that can happen is if that's happening long enough and it's getting sore, you can actually pull that growth center right off. And this is a picture of this part of the pelvis on this side, down here where this athlete popped this piece of the apophysis right off. And these are the ones that come in that are really uncomfortable. And they usually feel a pop, have a hard time walking, can't quite get comfortable, etc. These are frequently missed because a lot of people think if you pull your groin, you don't need an x-ray. I mean, it's a pulled muscle, let's stretch it, let's rest it. And then actually, these ones get missed a lot. So when a young person comes in with a hip or groin pain, they typically get an x-ray in our office just to look for the development of the bony pelvis. The treatment is usually staying off of it. Sometimes even crutches hurts too much. So the kids will just sit on the couch in a flexed position for a little while. These take about 4 to 6 weeks to really have a chance to heal. You have to treat it like a broken bone, just like you broke your arm. Now, there's no way we can put you in a cast or anything like that. But you don't want to stretch it. So the last thing you want to do with this kid is work on some soft tissue work and stretching them because you're just going to be tugging on this injured part. The challenge is returning to play. Usually at about 4 to 6 weeks, they're feeling better. And sometimes we'll let them start doing some light activity. But the biggest complication of this injury, it always heals. They heal really, really well, believe it or not. But re-injury rates are really high because we don't always know how long it's going to take. Some kids, it's more like 6 weeks and they're ready to start getting back. Some kids, it's more like 12. So that period between 6 and 12 weeks, we just slowly introduce activity and see how they do. If they have any discomfort or achiness, we pull them back. All right, knee pain, patellofemoral inflammation. So this is a generic term that I really don't like. It's also known as anterior knee pain, chondromalacia patella, runner's knee, patellofemoral pain, patellofemoral dysfunction. This is just generalized pain on the front of the knee, usually around the kneecap, sometimes more on the inside or the outside. And it's because the kneecap sits in a groove like this. And when you move and run, there is a quad pulling force and a patellar tendon tug, and it just pushes the bone here into this bone, and it causes a lot of inflammation of the cartilage in between. Usually it's just diffuse pain, worse with squatting, stairs, sitting, running. X-rays aren't usually helpful, but in the developing athlete, we usually do them because we're looking for other problems that are more serious, and we want to rule those problems out. Things that contribute to it are individuals who have single leg squats that look like this. So girls, as they're going through their adolescent growth spurt, tend to get very weak in their hip muscles, and they tend to have a lot of this movement of their knees. That causes inflammation. Kids who have a lot of pronation of their feet also tend to have a lot of patellofemoral inflammation. So when I have somebody come in, those are the things I'm going through. I'm looking at their flexibility, I'm looking at their strength, I'm checking their feet, making sure their alignment is okay, and then lastly, go back to their volume. All right, Osgood-Schlatter. So the Osgood-Schlatter technically is Osgood-Schlatter disease, but it is not a disease. There's nothing disease particularly about it. It is inflammation of the growth center or apophysis at the front of the shin here from repetitive pulling of the patellar tendon. Now, it occurs during times of rapid growth. Some kids are more susceptible to it than others. It's usually shows up as tenderness right here in the front of the knee, sometimes with a big bump, sometimes without a bump, and sometimes there's swelling around there. Usually it hurts worse when you're squatting, you're lunging, you're doing quick stops and change of direction. It's pretty easy to pick it up on exam because of how the area of tenderness isn't really around the kneecap, it's a lot lower down. X-rays are helpful, partly for us to figure out where you are in your skeletal maturity and estimate, how long is this going to bug you? Is everything looking okay? This is a pretty classic X-ray of an Osgood-Schlatter where the growth plate's coming along, the tendon comes down and tugs on that area and causes it to get fragmented and irritated. These ones are tough, a lot of activity modification, avoiding things we know are bothering them. So deep squats, repetitive lunges are usually a tough one for these kids. Icing can be helpful, especially after practice for pain control. Patellar tendon straps, some kids find that helpful. You can use pre-rep, you can use different kind of KT tape, that sort of thing. And then foam rolling the quads to improve flexibility can be really helpful. It's really hard for kids who are tight in their quad muscles to stretch when they have Osgood-Schlatter because flexing their knee up puts stress in the front of the knee and it really hurts. So foam rolling the front of the quad and hip flexors can be really helpful. In cases where it's chronic, sometimes I will get physical therapy involved, partly to help these athletes build their hamstring muscles some more so they're not using their quads so much with change of direction and movement, and that can sometimes help them take some stress off that growing area. This is a repeat slide, but it's just a different area. So it's the exact same thing as Osgood-Schlatter, but instead of happening down here, it happens up here on the distal pole of the patella, right up in there. The causes are similar. This happens in younger kids. This is going to be a couple years before this one. And in fact, you can't really see it on this X-ray here. This kid doesn't even have this apophysis in the front of his knee developed yet. This is still up in here. These ones are really similar to Osgood-Schlatter. The only time they're different is if they're really, really flared up or we see that the piece has gotten pulled away. Sometimes we will immobilize these kids and they'll go into a knee immobilizer for a couple of weeks to let that bone have a chance to recover. Shin splints are pretty common, otherwise known as medial tibial stress syndrome. It's inflammation of the soft tissue on the inside border of the shin, so right in here. A lot of times when you have shin splints, it's lower down, it's a larger area that's affected, and actually as you warm up, you might start feeling a little bit better. X-rays are helpful at ruling out other things, but can't really help you make the diagnosis. The treatment options are typically the risk factors are, again, the too much, too fast, too soon, and as well as pronation. So the things that we always look at when kids come in are, what does their foot alignment look like? Cleats are notoriously flat with no arch support. So a lot of times we'll talk about getting some inserts or arch support in their cleats. This is somebody who took a Dixie cup and froze some water in there, and this is a block of ice. And so ice cup massage along the inside of the leg can help with the symptoms as well. Stretching of the calf muscles can be useful. And then sometimes modifying activity, decreasing some of the running, and then slowly reintroducing it can be helpful. Also, at the beginning of the season is when these are most common. So when kids show up at practice, especially the ones who have not necessarily been doing a lot of training, getting them into some training ahead of time can be really helpful. I mean, easing them into their volume of running can be really helpful. Kid stress fractures in the lower leg are also not uncommon. These are mechanical overload of bone. I put this paper clip here to remind me to use my favorite analogy, which is a stress fracture. It's a process where the breakdown of the bone tissue from just normal training exceeds your body's ability to repair it. It's kind of like taking a paper clip and bending it back and forth over and over and over till it gets that warm feeling. That's a stress reaction. If you keep bending it and it cracks, that's a stress fracture. It's very similar symptoms to the shin splints. The things that are different is it tends to be a more localized area. It gets worse the more you do. Typically, it's a little higher up. X-rays can show changes associated with a stress fracture. Like you can see here on the bone as it comes down, it's nice and smooth, and there's this lump right here. That's a healing stress fracture. But in the early stages, this isn't always abnormal. So just having a normal X-ray does not mean you don't have a stress fracture. MRIs can always show you a stress fracture, but we don't always do MRIs. Those are kind of case-by-case basis on the situation and the exam findings. Stress reaction, stress fracture treatments, again, it's a continuum of how much bony injury happens. And the rest, it's usually a 6 to 12-week rest period from impact to get these to heal. So not small amount of time. So you really don't want to get into this situation. So how do you prevent this? You treat shin pain early. So if you have shin splints and you ignore them and you run through them, you probably are on a trajectory to end up with something like this if you're not careful. Low back. So this is the one I wanted to add in. So spondylolysis is a big long word. We also call them a pars fracture. It is a common cause of injury and back pain in young athletes. Traditionally, we always talked about it being in gymnasts and dancers because they bend backwards so much. It's a soft area of the developing spine. A grown-up or a mature skeleton is not going to develop a stress fracture back here, but a teenager will. This is pain with extension and twisting movements. So when you bend backwards and twist, it puts a lot of load on the bones here, and they give way just like the other stress fractures we talked about before. The diagnosis, sometimes we can see them on X-ray. So if you look at this bone here, it's nice and solid. When you look at this bone, it comes up and there's this gap in here, and that's a little pars defect. Usually it's not this obvious. Usually we end up having to do an MRI to find it. These ones we don't want to miss because they do lead to long-term issues. If you look on this spine, obviously this person has developed a pretty big defect, and the bones here, this bone is sitting ahead of that bone, and that can cause slippage there. So these can become surgical. We do want to be careful with them. Usually if you have back pain that's going on for more than a couple of weeks and it hurts when you extend backwards, that's a time where we need to kind of check in and see if we have evidence of this going on. Preventing this, hamstring flexibility is a really big one. The tighter your hamstrings are, the more it causes you to arch your back. So making sure your hamstrings stay nice and loose is important. Core strengthening, especially during the growth spurt. And then extension activities, repetitive shooting and hitting long balls. So if you have somebody who wants to stay after practice for an hour and work on their shooting, that's going to be somebody who, should be a little bit mindful. If their back starts bugging them, they should really back down because that's their body telling them that it's too much. Stress fractures. Again, I'm going to sound like a little bit of repetitive here because it's much the same. So in the feet, these usually are a dull achy pain that becomes more sharp. Sometimes we can see them on X-rays. Again, here's a stress fracture on an X-ray. Sometimes we can't, and we have to go the MRI route, and we can see a stress fracture right in here. Now, whether or not you have a stress fracture in this bone versus this bone versus this bone, so the fifth metatarsal, the second metatarsal, the navicular in the feet, they have very different treatments, very different outcomes. So usually with the ones in the middle of the feet, those all get better with rest. But if you have a stress fracture here of the fifth metatarsal, that can frequently require surgery and need a screw put in it. Same thing with the navicular; those can need a screw. So you definitely want to catch those early with foot pain and make sure that we're not overdoing it. Seaver's disease actually gets 2 slides because I see heel pain all the time in the office, and I'm gonna, in about a month, once the soccer season really gets rolling, it's gonna increase. So this is again the same thing, the same concept as before, is inflammation of the growth center on the heel. There are two forces at play on the heel bone when you're running, or the calcaneus. One is the Achilles pulling up, and the other is impact on the ground, where you're hitting the ground. It's really common. It really is uncomfortable for these kids. It tends to be the younger kids, girls younger than boys. It's pain on the back of the heel, pain with walking. A lot of times it's worse after practice. They'll be hopping around on their tiptoes. Actually, this can be really misleading. So just real quick, there's usually not swelling and redness. This is just a funny slide. There might be a little fullness, but not usually. Usually the heel looks fine. The kid just looks miserable. Actually, this can be really misleading because it is normal for this growth center here to have fragments. So some people will have heel pain, see an x-ray like this and be like, oh no, I broke the growth plate in my heel. That is not what's going on here. And in fact, there have been studies that have shown that the degree of fragmentation does not correlate with the degree of symptoms. So it just tells us that the growth plate is open and susceptible to developing this type of inflammation. So contributing factors are recent foot growth. If you've had to buy new size of cleats, heel pain usually goes along with that. Really tight calf muscles, tugs on the growth plate, a large volume of running, foot pronation is a big one, and then cleats. Cleats are inherently flat and really hard depending on the stud placement of the cleats. So things that I suggest is, one, are ice baths. These are two creative ways at home you can ice bath. This is a big stock pot with the dog drinking out of it. This is a cooler on the road in a hotel. You know, it's just submerging the heel, the whole foot in ice water is really the best way to ice it, because this bone is circular. It's like a knob. And so putting a bag of ice on it might get some of it, but it really doesn't penetrate deep down inside. Stretching of the calf muscle to either sitting or standing is really important. Strengthening can be helpful as well if you have a kid who's a really hard heel striker when they run. Some athletes prefer heel cups in their cleats, or even their daily shoes at school. In cleats, sometimes they shift around when you change direction because they're squishy. Some kids who have a lot of pronation will actually put an insert like a black superfeet into their cleat, and not forever, but just while this is going on, to kind of change the alignment of the foot and relieve some of their heel. Some other creative solutions that patients have told me have really helped them, and again, it's going to be different for everybody, are a new pair of cleats. So cleats have different placements of studs, and sometimes if one stud is really pushing hard on the heel bone, if you get a different pattern, it can help. Some kids will use their running shoes for more of their fitness rather than their cleats. Some kids find that on hard turf, wearing a turf shoe is easier. Again, that's moving that the stud placement around. Ibuprofen is fine. I always tell my patients that heel pain can cause absolute misery, but it's unlikely to cause long-term damage. So unlike some of the other stuff I spoke about in the previous couple slides, this one doesn't usually cause damage. Sometimes it gets so bad that we do have to immobilize, put somebody in a boot for a week or two, just to really calm things down, especially in kids who just don't have the ability to slow down. All right, we're almost to the end of these ones. Iceland's is, again, same thing, but this time it's on the base of the fifth metatarsal on the outside of the foot. Pain and swelling on the side of the foot, not red, but this is where it hurts. It looks like that on x-ray. The only thing different between these and maybe a Sievers is sometimes wider shoes, because this will happen sometimes in kids and they'll get really swollen out here. And then when they try to put a tight cleat on, it puts pressure on there. So in those kids, temporarily switching them to a cleat that is wider can really provide some relief. So some key points. I'm just going to go through a couple slides here at the end, and then we're going to switch over to some Q&A. So some key points are volume, specialization, recovery, treatment, and then when is it okay to play with pain. So volume, again, this is just me reiterating a lot of what I said before, but muscle fatigue increases the stress on the bone and the joints. It's often not noticed until after there's pain. So it's not like the kids are coming home and say, my muscles are tired. So it's really on parents, coaches to look, to take a step back and look at the overall load that the athlete is under to kind of predict or when this might be an issue. And it all adds up, whether it's daily practice, individual training with a one-on-one with a coach, or even on their own, multiple games per day, multiple teams, even the same sport, a soccer, futsal, if you're going every day of the week, it really puts a lot of stress on the developing skeleton. Early sports specialization. There's a lot of discussion about this, and there's a lot of discussion that athletes who do multiple sports have less injuries, and developing your overall athletic fundamentals is what we like to call it, is necessary for top performance. Those are things like your aerobic fitness, your flexibility, your strength, and your agility. Now, this all sounds good on paper, but in reality, as a parent, it can be a little bit daunting to say, all right, your kid, is going to soccer practice 3 or 4 days a week, plus 2 games on the weekend, plus, oh, by the way, they need to play another sport so that they can be a better athlete and not get hurt. How do you put this all together? When they're little, it's easier. So for example, when my kids were little, I was running all over the place. But at this age, they practice once a week. There's a season to their sports. We shift from one to another. As they get older, that just becomes not possible. And as kids get older, we have to remember that there are other ways to develop these athletic fundamentals here other than signing them up for an organized sport. So as I was going through my slide, I was thinking back on, what are the other things that we've done that have helped? And whether it's, developing upper body strength, balance, climbing abilities, coordination, even now, like I don't have time for my kids to be doing a zillion different sports and work. It's mountain biking, it's golfing, it's doing mud runs, it's doing other things that are physically active and developing them as athletes that aren't necessarily signing them up yet for one more commitment. But it is varying. It's taking a day off from one sport and doing something else. So recovery, the benefits of training occur during recovery, and I find that so many young athletes lack the ability to figure this out on their own, and they really need talking through it can really help. That you can train all you want and you're breaking your muscles down to try to get them stronger, but when you are resting at home and sleeping, that's actually when you're getting stronger. That's when tissues heal, they adapt, they strengthen. So this recovery is really important after long tournament weekends, after camps, tryouts, after season. So the goal is 2 to 3 months a year off of your primary sport. It can be divided into 1 month breaks if it's 3 weeks in December and 5 weeks in July. It doesn't have to be one solid chunk. And the goal is 1 full day of rest each week. Now on your rest day, if you want to do some stretching and some core strengthening, that's very reasonable. Get in the pool and swim, that kind of stuff. The active recovery is fine, but not pounding on the same parts of your body. And then sleep is again essential, especially in our high school athletes. I mean, so many of them are cheating their bodies out of sleep, and so making that a priority is important. Consequences in the short term: suboptimal performance, loss of playing time. Long term: chronic injury and shortened athletic career. I did my fellowship at Stanford. I took care of a lot of Stanford athletes as a team physician, and a number of them who had to prematurely retire and be done with their sport by the time they hit college because they'd beaten their body up in high school. It was sad. So it does definitely happen. So my rule of thumb is it's probably okay to play with pain. It doesn't interfere with performance, doesn't cause limping or change of mechanics, isn't getting progressively worse on a daily basis, and doesn't decrease the kid's enjoyment of the sport. You still want to go back and you're still having fun. But it is important to remember that playing with pain does make overuse injuries worse. And overuse injury is not going to get better by just pushing through it. But there's a time and place where you say, this is important time in the season. This is an important time in my career. Just knowing what it is really important. And making sure that you're kind of following these rules. So overuse injuries, early aggressive treatment is important. It limits the extent, it speeds the recovery, it decreases lost playing time. Complete rest is usually not necessary. I very rarely tell anybody to just rest and do nothing. There's always something you can do. So I focus on what they can do, whether it's getting in the pool, whether it's getting on a bike, whether it's working on their flexibility, their core strength, their upper body strength. There are plenty of things that you can do, but sometimes we have to change up what they are doing. Preventing them, a lot of it is understanding developing skeleton, adjusting during times of growth, managing training volume, making sure kids are recovering, and recognizing when they're getting injured, making sure they're communicating with their parents and their coaches, and making early modifications so that it doesn't become a bigger issue. And then the last thing is when should you come see a doctor? Usually 2 weeks. It's going on for a while. It's getting worse even though you've rested. There's some swelling in the joint. There's tenderness over a bone. You're not right sure what it is. You want to make sure it's not something that is going to be a big problem, or if there's recurrent injury. Those are times where I usually tell kids it's probably a good idea for us to check in and at least chat about what's going on. I think that's the end of it for me. And now I'm gonna turn it over to Amy and let her help me manage some Q&As.
Thank you, Dr. Boyd. That was very helpful. Okay, so I'm just going to start answering questions. If you are asking questions, if you have any, please feel free to put them in the chat in the Q&A. Okay, so first question, what's the difference between minor muscle tears being an injury versus soreness from exercise?
Right, that's a great question. And so minor muscle injury and soreness from so muscle soreness is injury to the muscle. But it is not to the extent that it's causing tearing and loss of muscle function. But if you push your muscles to the point that they are sore, you have to, in your mind, imagine that that's muscle tissue breakdown and it needs to recover. So I would say sore muscles are at the very, very beginning of the spectrum of a muscle tear. So if you push through a sore muscle, you definitely are increasing your risk of having a more significant tear. All right, Amy, do you want me just to go through some of these?
Yeah, or I can, just ask the question so everyone can hear it.
What's the next one? For ACL injuries and recovery time? I think Dr. Chan did a talk on that. No, Dr.
Yeah,
Shin.
I was going to say, I'm going to put that in the chat. There's a link to another webinar we did on that, but if you have anything else you want to add, go ahead.
It's about a year. From start to finish, it's about a year. It's a little bit different for every athlete, but that's the kind of the short answer. My 9-year-old son plays goalkeeper. One of his most repetitive actions to be standing up from a dive, usually with the help of his hands, which is safer for his hands or wrists. Standing with an open palm or a closed fist. Probably a closed fist, just because you're not extending your wrist as much. And then also your fingers aren't exposed. What about ankles? My son's ankles ache regularly, worse around practice and games. So pain that's along the front of the ankles is usually mechanical, and it's usually related to the support or lack of support within cleats. So that's when I usually look at the foot mechanics to see if we need to add some inserts or arch supports into the cleats. The pain on the back and the heels more severe, but that front pain is usually mechanical. This is not an easy one. How can we get doctor to listen to us as parent and not dismiss the pain our athlete is having? Almost always they dismiss it because they are an athlete or aren't an athlete. Yeah, I think for the most part, I think sorry, I'm reading more questions. I think for most part, making sure that you're, if it's your pediatrician or your regular doctor, if they're, not as familiar with sports, it can be a little bit tricky. And a lot of times those kids end up in our office just because having the discussion of, how do we manage this in your season, looking at the whole year training plan, which competitions are important, are you a junior, are you a freshman, that sort of thing. So I think it's really finding the right provider. Even within our pediatric groups around here, there are quite a few who do a nice job with athletes. Let's see, what is the rule of thumb on pain? Is 3 out of 10 okay? Anything above is a warning sign. I usually will tell kids, 3 out of 10, but I really, I think kids don't do great with the number scale. I think adults, it's easier. And I have kids who come in all the time and say, my pain is a 10, and, clearly it's not. I like to watch their mechanics. If they're miserable, if they're limping, if they're really uncomfortable, and they may put on a tough face on the field, but when they get home, they're like hobbling and crawling around the house, that would be too much. So I think gauging their level of discomfort, if it's not changing the way they move, but they just say, oh man, I'm sore today, and then you do something about it, and then they're back the next day and they feel okay, I'm okay with that. It also, I think the timing of the season, so if you're, the finals of state cup and your heels are really bothering you, and you want to take some ibuprofen and kind of gut it out, fine. If you are in the beginning of the season, in the first preseason tournament, and your heels are bothering you, probably not the best time to gut it out, because you're just going to make it worse, and it's going to make for a really miserable start to your season. Ankle braces recommended for ankle soreness. Typically, I do not. The things I usually use more ankle strengthening and stability exercises. So, calf raises, single leg balance exercises. Really working on getting the ankles stronger as opposed to mechanical braces. I will use ankle braces for ankle sprains and acute injuries, but not chronic ones. You recommend shoe inserts. So there are different options. I know that the different soccer stores have different ones. The black super feet have been shown to fit pretty well in cleats. They're not perfect. You have to rip out the gluted insole in your cleat, but the black super feet do tend to fit pretty well. And Curex also has some soccer specific ones that some of my patients really like. If a child has flat feet, should we specifically do anything during soccer training? So if it was a 5 and a 9-year-old, kids at that age typically will have really flat feet. If a kid has flat feet, I don't do anything about it. There's no, putting arch support in a shoe with a kid with flat feet doesn't prevent them from having flat feet later in their life. Your feet are going to do what they're going to do. I only intervene if there's pain. So if they start to develop arch pain, shin pain, ankle pain, heel pain, then I might consider adding a little bit of insert or arch support. But if they just have flat feet and they're just not bothering them at all, I don't really worry about it. I do on those kids though, when they get a little older, like middle school, I just remind them it's really important to wear running shoes in PE when they're running the mile, not their Vans or Converse. Our knee brace is recommended for Osgood Schlatter. So the knee brace that that patellar tendon strap is the one that mechanically would put support on the front of the knee. I would say this is just a rough estimate. Half the time kids tell me it doesn't help at all, and half the time they say it helps. There's a whole bunch of different options that are available. The tape is probably the most comfortable, but it's worth trying. So I usually tell kids you can give it a try and see if it helps, and not a very expensive investment. But it doesn't help everybody, and it doesn't necessarily help the long-term trajectory healing. It's more of a symptom management. Is it better to see a PT first for pain or to see a doctor? I would typically start with a doctor just for screening purposes. But that's really kind of up to most good physical therapists. If they assess and think that more intervention is needed, they're going to refer over to one of the physicians anyway. But that's obviously I'm biased on that one. But I love my PTs. I could not help athletes the way I do without them. So they're a vital part of our team. What are some preventative things we can do for our goalkeepers to avoid common goalkeeper injury? So goalkeepers are definitely probably the higher risk position on the field, just because there's a lot of contact, unexpected contact, etc. The injuries that I typically will see in goalkeepers, other than concussion, which I'm not going to talk about right now, are some of the ones from the repetitive kicking, long balls, punting, things like that. So just being careful with that, making sure that they are staying very flexible in their hamstrings is a big one, just to make sure that when they're falling. And then the injury, other than concussion, the injury profile for a goalkeeper is very similar to a field player. I mean, again, it's a lot of avoiding the same repetitive movements, and a lot of the diving, I think, is probably one of the ones. They're good guidance for how much activity is too much for an 11-year-old boy who plays soccer and basketball. There was one study that a lot of these are done in Europe on their young athletes that said the number of hours that you have practiced and playing games should match your year in ages, right? So 11 hours a week. That doesn't include driving there, driving home, the 20 minutes beforehand when you're standing there. It's talking about physical activity. I think sometimes on those, when you're doing sports like that and they cross over, trying to avoid practices both sports the same day unless you absolutely have to. And if you have to, making sure that they have a full day of rest, not doing the 7-day-a-week thing. That's going to really be a grind. Again, there could be one week where it's not really an option because of what's going on, but then knowing that, hey, next week we don't have any games, we're really going to need to let your body have a chance to rest and recover. Can you recommend a website that provides recovery nutrition information for an 11-year-old? Do you have recommended protein shakes? Amy, did Dr. Balaji's presentation was super detailed and had a lot of really good stuff on nutrition and recovery. I know US Soccer actually has a pretty robust sports medicine section that has a lot on nutrition for young athletes. And for an 11-year-old, do you recommend a protein shake? only if you don't feel like they're getting adequate protein from their regular diet. I mean, a protein shake is easier to get down in a hurry. But if you can, get regular other proteins in them, that's going to probably be a better choice. A lot of the protein shakes have a lot of sugar, not a lot of fiber. But if you're having a hard time getting enough calories and enough protein in your athlete, it's not a bad way to do it. Hip strengthening for patellofemoral pain. Can you say more about that? So, that's probably a whole, patellofemoral pain and hip strengthening is probably a whole 20-minute talk, half an hour talk in its own, mostly because that same weakness that the athletes develop in their hips is the same one that puts them at risk for knee injuries. And so there's a lot of value to really working on core and glute strengthening. My favorite is a bridge, like a double leg or single leg bridge activity to strengthen the glutes. The FIFA 11 program has a lot of single leg jump balance exercises. A lot of those are really designed at hip strengthening. So if you're looking for kind of something to do on your own, a lot of those exercises are designed for hip strengthening. Is massage helpful? And how do you find someone who works in this age group? So massage can be helpful in kids who are really tight. I don't recommend really getting up on the kind of the bony insertion or the origin of the muscle, staying more into the muscle belly. I usually use physical therapy for soft tissue mobilization and soft tissue work, so I don't usually refer out to massage therapists. I'm sure there are plenty out there who do a nice job with the younger athletes. The younger athletes tend to be a little more sensitive and don't need the deep tissue work. They just don't have as much muscle bulk. So I usually use more of the massage gun, foam roller, home massage sort of things, or have physical therapy do it.
Okay, well, I think that's all of our questions. Thank you, everyone, for taking the time to listen, and thank you, Dr. Boyd, for this very helpful presentation. I put one more comment in the chat. If you have really specific questions about your child's situation, and feel free to call to schedule an appointment with Dr. Boyd or another pediatric sports medicine specialist. Oh, hang on, I see a few more. Oh, thank you. Great, just making sure we got all those questions. Awesome. Okay, well, thank you, everyone, and I hope you have a great weekend, and I will be sending out the presentation afterwards. Thanks, everyone.
Oh, great, thank you.